Welcome, esteemed colleagues, to our exploration of the thoracic spine, where infections and tumors can lurk, challenging our diagnostic skills. Brace yourselves for a journey through the intricacies of this vital region as we delve into the world of Pott's spine, fibrous dysplasia, and the formidable multiple myeloma. Tuberculosis general features. The ancient scourge of tuberculosis, also known as Pott's spine, rears its head. While its incidence was once on the decline, it has stabilized and, in some regions, is even on the rise once more. Individuals of low socioeconomic status are particularly prone to acquiring this insidious infection. The spine, being the most common location for musculoskeletal tuberculosis, presents with an insidious onset of back pain, decreased motion, and tenderness. Interestingly, the symptoms can be relatively mild compared to suppurative infections, leading to a delay in diagnosis, a cautionary tale for us all. Tuberculosis radiographic features. When it comes to radiographic features, tuberculosis can be a trickster, presenting nonspecific findings that make differentiation from suppurative infections challenging without clinical information. Bone sclerosis may be limited early on, but with time, it can become exuberant. The amount of destruction can be severe, leading to the dreaded gibbous deformity. The most common level affected is L1, and we may encounter paraspinal line deviation from spinal abscesses. Additionally, subligamentous spread can lead to anterior vertebral body erosion and skip lesions, keeping us on our diagnostic toes. Fibrous dysplasia general features. One potential culprit for our patient's chest wall deformity is fibrous dysplasia. Ribs are commonly affected by this condition, which is the most common benign lesion of the rib cage. Interestingly, patients are often asymptomatic unless a pathological fracture or deformity occurs, prompting a visit to our esteemed offices. On the radiographic front, fibrous dysplasia presents as radiolucent, expansile lesions with a soap bubbly appearance and a rim or rind of sclerosis. We may also observe a ground glass matrix, adding to the diagnostic puzzle. Polyostotic lesions tend to be unilateral, and rib lesions may produce the extrapleural sign, a subtle yet significant clue in our diagnostic arsenal. To further solidify our understanding, we have visual representations of both monostotic and polyostotic fibrous dysplasia. These images serve as valuable resources, aiding in pattern recognition and enhancing our diagnostic acumen. Our next case study introduces a 65-year-old female presenting with chest pains of insidious onset. This scenario challenges us to consider a broader spectrum of potential etiologies, including the formidable multiple myeloma. Multiple myeloma, the most common primary malignant bone tumor, typically affects individuals between the ages of 50 and 70, with a higher prevalence in males. This malignant proliferation of plasma cells frequently involves marrow-rich bones, making it a formidable foe. Bone pain, often worse during the day, is the most common complaint, accompanied by weight loss, cachexia, weakness, and recurrent infections, a constellation of symptoms that should raise our suspicions. Radiographically, multiple myeloma presents with osteopenia as a common finding. Pathological compression fractures can occur, resulting in the ominous-sounding vertebra plana or wrinkle vertebra. While the pedicles are usually spared until late in the disease, a phenomenon known as the pedicle sign, we may encounter punched-out lesions in the ribs with no surrounding sclerosis or periosteal reactions. Interestingly, bone scans are often cold in multiple myeloma cases. Other neoplasms of the thoracic cage. Lest we become complacent, this slide reminds us of the myriad other neoplasms that can afflict the thoracic cage. From skeletal metastases and lymphomas to osteosarcomas and chondrosarcomas, the list is extensive, challenging us to remain vigilant and well-versed in the nuances of these conditions. We must also consider benign neoplasms such as enostosis, osteoid osteoma, osteoblastoma, enchondroma, and others, lest we inadvertently subject our patients to unnecessary interventions.